Hello everyone, and welcome to another episode in my spine world. Today I'll be talking about navigation in spine surgery. Navigation is a group of technology which allows the surgeon to access real-time, three-dimensional and virtual images of the spine in relation to the surgical instruments intraoperatively. The primary goal of navigation is to optimize the surgical intervention by providing the surgeon with advanced visualization of the operative field and to see the exact position of the handheld instrument in relation to the bony anatomy. Surgery has come a long way from the ancient times when the surgeon had to cut open and then actually see the pathology what was inside. These days, we have the luxury of advanced imaging like the MRI scan to see the pathology inside the spine and the spinal cord, and then go on to plan the surgery as well as do the surgery. But the surgery field or the surgical field visualization was still limited inside the operating theatre. Hence, the wound used to be bigger, and so was the scar. With the availability of navigation, a surgeon can precisely see where he wants to cut, and with the help of navigation instruments and advanced surgical instruments, a surgeon can precisely do the surgery with the minimum amount of cut possible, and hence minimally invasive surgery with maximum safety is possible these days. In the future, augmented reality will further revolutionize spine surgery. It will also bring a sea change in the way we operate and also the way we train the young surgeons. Having said that, let us examine what is a navigation and what is navigation in spine surgery. So today I'll be discussing about what is navigation, why we should navigate, how we can navigate in spine surgery, what are the advantages and the disadvantages of navigation. Navigation is a process or activity of accurately ascertaining one's position and planning and following a route. We have been doing this almost every day when we travel from one place to another or when we use a Google map to locate and travel. Surgical navigation is a surgical concept and set of methods that use computer technology for surgical planning and for guiding or performing surgical interventions. Like I told you before, it is a combination of image acquisition and processing that is followed by intraoperative navigation. Surgical navigation has been used in various surgeries, including various orthopedic surgeries, neurosurgeries, and of course in spine surgery. For example, navigation has been used in total knee replacement surgery to guide and precisely place the implants inside the knee. Surgeons sometimes also use navigation for a total hip replacement to place the implant in the exact orientation that they need for maximum stability. Navigation has also been used in trauma surgery, especially in pelvic fracture surgeries where you want to place a screw into the bone of the pelvis, navigating a very narrow corridor without injuring any of the major structures including major nerves and vessels. Neurosurgeons also use navigation for better tumor localization and to minimize damage to the surrounding structures. Spine surgeons also use navigation to safely and accurately place various implants like pedicle screws, also navigating a very narrow, safe corridor. Now let's go on to examine why do we need to navigate in spine surgery. Here's an example or a picture on your right which shows the body and the pedicle or a lumbar spine vertebra with a pedicle screw inside. So you can see that there is a very narrow corridor for you to pass these pedicle screws. And here's a pictorial representation of the lumbar spine vertebra. This is the vertebral body and this is the pedicle here, and here is the superior and the inferior articular process. And this is the superior view which is showing the body as well as the pedicle as well as the transverse process. Spine surgeons have been using pedicle screw for various surgical techniques and have been placing it with quite amount of frequency. Navigation makes it safer. So here's another good example of why we need navigation in spine surgery. Here you can see the implants which are placed in the cervical 1 and cervical 2 vertebrae, and you can see the implant actually navigates a very narrow safe corridor between your vessels which is a vertebral artery, as well as the neural elements, which is right in the middle. And also, sometimes the spine might be very crooked or scoliotic, and hence passing the implants or pedicle screws or any sort of screws into the bone of a crooked spine becomes even bigger challenge, and navigation helps you to safely do it and gives the surgeon more reassurance and confidence. In other words, it helps a surgeon navigate safely through what we call as tiger territory. So here's another good reason why a surgeon would love navigation, so as to avoid complications like these where the screws are actually injuring the vertebral arteries in the cervical vertebrae, as well as possibly injuring the spinal cord or some of the nerves in the lower lumbar area. There are enough studies out there which tells about misplaced pedicle screws, and it actually ranges from 14% to 55% depending on the various skills of the surgeons and the experience of the surgeon. But 7% of these misplaced screws result in some sort of neurological injury, and hence using navigation helps you to accurately place these screws without injuring major neurological or even vascular structures. Then you may ask, is it so difficult to place a pedicle screw or any implant in the spine? When we look at the anatomy and landmarks for passing a pedicle screw, you have various landmarks including your facet joints, transverse processes, but there is no actual visualization of your pedicles or the body or the spinal cord or the blood vessels sometimes when you pass a pedicle screw. So there is a potential risk of injuring the nerve or spinal cord or sometimes even a major vessel. It is much easier to do these or passing a pedicle screw into the lumbar vertebra, but it becomes difficult as you go up to the thoracic spine, and becomes even difficult to pass a pedicle screw into a cervical spine vertebra. For example, when you look at the thoracic spine pedicle anatomy, you can see that the width gradually decreases right from thoracic 12 to thoracic 2. If we look at the landmarks for passing these pedicle screws in a thoracic spine, it varies slightly from vertebrae to vertebrae, and as we go up from thoracic 12 to thoracic 1, and also the diameter of the pedicle also varies, and sometimes even we can encounter what we call as a dysplastic pedicle, where the pedicle has not been developed properly, and it becomes even bigger challenge to pass these pedicle screws. And also, if you look at the cervical spine anatomy, if you want to pass a pedicle screw, which is the screw which goes into this bone structure here, it has to navigate the very narrow corridor, which is around 5 millimeters between the vertebral artery on the side and the spinal cord on the other side, which is a real tiger territory. It is also a challenge to pass these pedicle screws in a scoliotic spine, where the landmarks may not be so clear-cut. Hence, I have given you ample reasons of why we should use navigation in spine surgery. Now let's go on to examine how accurate are these navigated screws or implants. There are enough studies about navigation or image guidance consistently reducing pedicle breaches to less than 5%. Now we have examined why we need navigation. Let's go on to see how we can navigate, or how do a spine surgeon navigate during a spine surgery. Navigation has been used in spine surgery for a very long time. For example, fluoroscopy with 2D images has been in the field for so many years and is still being used for various spine surgeries. And these days, there is 3D navigation, which is making use of cone beam CT or CT scans, and these systems provide projections of the operative field and instruments with imaging in 3-dimensional axis. The goal of navigation is to track surgical instruments and anatomy in the operative field relative to a registered reference point. Now, optical tracking actually uses cameras, as shown in the picture here, that project and detect a reflected infrared light from reflecting spheres, which is attached to the patient's body. Or sometimes they use even light-emitting diodes. So this will be the tracking area with the reflecting spheres attached to a bony point on the patient. Then we have this navigated pointer or various instruments with tracker balls and tells the surgeon where he is in the operative field. So for navigation, you need either radiological imaging, it could be a pre-op CT scan, or it could be an intra-op 2D C-arm, or even a 3D C-arm like an O-arm, or even a mobile CT. And also you need a camera-based tracking system. Sometimes you can use with a tracker or can be a trackerless system as well. So in short, when we look at the history of navigation, it started off from 2D fluoroscopic navigation with an AP or a lateral X-ray, and then went on to a 3D fluoroscopic navigation using isocentric C-arm. And these days we use a 3D CT navigation with a pre-op CT which has already been done, or you can even take an intra-op CT during the surgery. Surgeons have been traditionally using the 2D spine navigation using AP and lateral view X-ray for quite a period of time. And then came the isocentric C-arm, which helps to recreate three-dimensional pictures of the bony anatomy and helps in navigation. One of the disadvantages of using an isocentric C-arm is actually difficulty in creating a three-dimensional picture of a spine anatomy, especially in spinal deformity. In a normally aligned spine, it can be isocentric, but in a spinal deformity, getting an isocentric picture using an isocentric C-arm becomes a difficult task. And then came the 3D spine navigation using either a pre-op CT scan or even an intra-op CT scan, and also uses intra-op surface mapping registration. These days, CT-based imaging systems or navigation is the most common. The most commonly being used are the O-arm or a mobile CT, the Aero system, and the 7D Envision system. Here is a picture of the O-arm, which is used in 3D CT-based navigation. And along with the stealth station navigation, the O-arm system provides an enhanced 3D visibility and surgical feedback. As you see in the picture, here the surgeon is passing a pedicle screw using the O-arm and the stealth station. So does using navigation slow a surgeon down or increase his surgical timing? There are enough studies comparing operative time using navigation and not using navigation. And yes, it does tells you that navigation slows you down, but not to a great extent. But most importantly, it helps you to navigate, especially the pedicle screws or instruments, in a safe manner and avoids any clinically significant implant breaches. So there are different workarounds for increasing or pacing the surgery, like having a smooth workflow already in place and planning well ahead helps to pace the surgery better. One of the questions that would be going through most of the minds of the surgeon and the patient is, am I exposed to increased radiation since I'm using a CT-based system for navigation? When we compare various radiation exposure to patients from different modalities, including a fluoroscopy or a CT-based navigation, CT-based navigation in fact has got lesser radiation compared to a fluoroscopy. So let's go through some of the advantages of navigation. It helps in more accurate and safe placement of various instruments in the spine. There is less exposure to ionizing radiation. It is useful in cases with complex anatomy like scoliosis, and it meets higher patient expectations and lower tolerance for major surgical errors, and is also a good training adjunct to train young surgeons. There are also disadvantages to navigation, which includes high cost of equipment, learning curve for the surgeon, which includes 4 to 6 months, and also increase in a surgical or a procedure time. Does it mean that the surgeon who uses these navigation systems are the big boys with cool toys? The answer would be a big no, because navigation is only a small part of the whole surgical procedure. You also need, as a surgeon, an intensive task, which includes a knowledge of the anatomy, of procedure cases, experience of the surgeon, and also the surgeon needs a manual dexterity, precision, strength, and tool manipulation, and also determination for information, judgment, decision, and execution. In other words, screw placement or an implant placement is but a small part of spine surgery. And always remember, a fool with a new tool is still a fool. There are still a few unanswered questions with regards to navigation. For example, does navigation make you less of a surgeon because you are taking the help of a machine to pass pedicle screws? Is it cost effective for the patient? Does it change the way we train our residents, or in other words, are we spoiling them by using navigation? Or is navigation ubiquitous? Or in other words, can I do a spine surgery in a country without navigation? Or is it going to be the standard of care in the future? Will there be lawsuits if I don't use navigation? But the most clear answer currently is that navigation allows for an increased level of patient safety and an overall reduction in patient morbidity. And hence, the future of spine surgery is still very exciting. That'll be the end of this episode, and thank you for watching. And please do visit my website and follow me on Facebook and LinkedIn. The links will be given in the description below. Stay safe, stay healthy.